Okay, so now we welcome Dr. Finella Craig. She's a consultant at the Paediatric Palliative Care team at the Great Ormond Street Hospital in London, and she's going to talk to us about respiratory symptoms. So welcome, Finella.
Thank you very much, and thank you for inviting me to Rome. I'm having a lovely time. So I'm going to talk about management of respiratory symptoms, and hopefully what I'm going to try to do is a fairly practical and evidence-based approach. If you've heard me talk about this before, I have added in a few extra studies and a few new things, as well as retaining some of my old favourites. So I'm really just going to focus today on symptom management and four main respiratory symptoms. So dyspnea, cough, hemoptysis, and retained secretions. What it's important to remember with all of these is a multimodal approach to management. Think about the underlying cause and, where appropriate, use disease-directed interventions. For example, in a malignant mass, you might want to use radiotherapy. So, as I said, I'm not going to focus on the whole holistic symptom management approach. I'm very much today going to focus on very specific symptom management aspects of care. So I'm just going to start with dyspnea. One of the reasons I am interested in respiratory symptoms is because I think they get neglected, especially dyspnea. We often hear people talk about pain and symptom management. Well, why don't we talk about dyspnea and symptom management? Why don't we talk about secretions and symptom management? We give pain a lot of attention, but these other symptoms can be just as prevalent, as you can see from this study that Joanne Wolfe did. In children with cancer, dyspnea was just as prevalent as pain and was just as distressing and was also quite refractory to treatment. So dyspnea is a very prevalent symptom, and it's also really, really frightening. Dyspnea used to terrify me until I started reading and learning more about it. And now pain frightens me more than dyspnea because I feel that I've got the tools to actually do something effective for children that are dyspneic. The first thing I would always recommend, a simple handheld fan. There's lots of evidence now to suggest that a simple handheld fan directed at the face, you want to blow it over this part of the face, so don't blast it in the face, don't waft it here, don't blast it here, just waft it gently over the lower face. If you blow it over the leg, the studies show it will make no difference, but if you blow it over the face, it will improve dyspnea. You'll get a faster recovery time. There's a reduced need for oxygen. I should say that all of the studies that I'm going to talk about today, unless I say otherwise, have been done in adults. So we're having to make a lot of inferences from adult studies. But this, time and time again in adult studies, it's been shown to be effective. It's cheap, it's portable, and it's really good first-line treatment for breathlessness. So I think everyone who works with children in palliative care, particularly end of life, should carry around a handheld fan. We don't quite know why it works. It could be that it just works by distraction. It could be that it empowers someone to feel that they're responsible for their own symptom management and they've got a bit of control. There's a theory that it stimulates the trigeminal nerve facial receptors, which makes the brain think that airflow is actually much higher than it really is, and that you're breathing better, so you feel less breathless. But it's a really, really good technique. We sometimes see a lot of people talk about open a window or put a fan on, have air wafting around the room. I could find no studies looking at a fan and wafting air around the room. It's about a fan blowing air gently over the face. So what about oxygen? That's the one we always reach for. We spend hours and a fortune trying to get home oxygen for children in case they're breathless at the end of life. Well, the good news is we probably shouldn't be bothering a lot of the time. Studies have shown that room air and oxygen via nasal cannulae are both effective, but actually, unless the patient's hypoxic, there is no benefit of oxygen over room air. So studies have shown there is a benefit of a handheld fan, which will cost you £1 and take you half an hour to go and find, or maybe €1. and is sold in every corner shop in London. That's easy to do. Oxygen is harder, and actually it's probably not that helpful. And so one of the studies looked at, I think, 239 patients. They had to be in oxygen or room air for 15 hours a day for 7 days. And that's where they showed there was absolutely no difference, whether it was air or oxygen. What they did find, though, was that patients who were more breathless to begin with were more likely to benefit from the oxygen, and usually within 48 hours. So there might be some benefit in the most breathless patients. Our go-to drug is always opioids, and for a really, really good reason. There's lots of evidence of the benefit of oral and parenteral opioids, so that's not in question. There's a lot of debate as to how they work, but they reduce air hunger and the ventilatory response to decreasing oxygen and rising carbon dioxide. They can also help reduce anxiety and that escalation, that anxiety, breathlessness, and you get more breathless, you get more anxious. So they can help with that. One of the things that is up for debate is what dose. Traditionally, we've all used 50% of the 4-hourly pain dose. But actually, one of the studies looking at that has actually concluded that 25% is just as good as 50%. So actually, if less is just as good, let's save a bit of money and let's prescribe at 25%, not 50%. And what about the fast-acting opioids for children who are really gasping and breathless? Well, there's actually some evidence now that fast-acting opioids are probably quite helpful. And there's one study that looked at this in children, where they used fast-acting fentanyl studies. It was a retrospective case note review. They looked at cases of 16 children, and they had had 70 episodes of breathlessness. And for those episodes of breathlessness, they had received fentanyl, 1 to 1.5 micrograms per kilo. And what they found was that 96% had an improvement in laboured breathing, and 79% had a reduction in their respiratory rate. So it's a bit of a limited study because it was just a retrospective case note review, but it's the only one I could find in children, and it did show that there's actually some benefit from a fast-acting preparation. There's also another recent study that was done in adults looking at the role of nebulized fentanyl. And in that study, they had 73 adult patients who had 360 episodes of breathlessness. And in 71%, there was a documented improvement in their breathlessness. So there's probably a role, definitely in adults, for nebulized fentanyl, and maybe something we should think about for children as well. Our other go-to drug, as well as morphine, is usually an anxiolytic and very often midazolam. And I know some people who use midazolam as their first-line choice, and some people who will use morphine as first line. So what should we be doing? Well, actually, there's really mixed evidence for the use of an anxiolytic. There's been certainly a Cochrane review that actually couldn't see any benefit of midazolam or any other anxiolytic for the relief of prevention of dyspnea. So they couldn't find any benefit over a placebo or any benefit over morphine. Another study, which is the second one down, found slightly different results. And what they found with 63 adult patients who I think they were randomized either to receive morphine or midazolam, they actually found that midazolam was slightly better. But the third study is one that I've really clung to. I really like this study. It wasn't strongly statistically significant, but it pointed towards an answer. And what they found was that round-the-clock morphine plus midazolam with morphine as breakthrough was the best combination for managing breathlessness. So a combination of regular morphine plus regular midazolam, and if you need to give something for breakthrough, give morphine. And that's better than morphine with midazolam breakthrough, and that's better than regular midazolam with morphine breakthrough. And what about integrative and supportive therapies? We really shouldn't forget about them, and I know we sometimes do. But there's good evidence in adult studies and there's evidence in some paediatric studies that these can be helpful in managing breathlessness. Most of the studies are not looking at acute breathlessness, but more long-term breathlessness, and a lot are looking at sort of self-management. So we know that psychosocial support alongside things like exercise training, teaching breathing control can be very helpful. We know that in children with chronic respiratory conditions, there's good evidence for self-hypnosis. And, maybe that's something we should be thinking about for the children that we know are going to get increasingly breathless. And maybe it's something that will help them when they're acutely breathless as well. And self-management strategies such as teaching breathing techniques. So we should always think about those. Moving on to cough. It's irritating. It's irritating for the person who's coughing, and it's really irritating for everybody else. It's distressing for the person that's coughing and for everybody else. It makes people anxious, it disturbs sleep, everyone gets tired and fed up with it, and it's really difficult to treat. So what should we do about cough? Well, sometimes a cough is because we're just not clearing those thick secretions, either because the secretions are too thick for us to clear or because our cough is too weak. You can do a little cough, that doesn't clear anything, or a nice big one. Much better, and I can really clear something with a stronger cough. But a lot of our patients obviously can't do a strong cough. So we can think about improved secretion clearance, so saline nebulizers or DNAs. And DNAs and 7% saline work much, much better than a normal saline nebulizer. And we can improve cough strength by using things like physiotherapy or cough assist. So think about secretion clearance in chronic cough. What about the medications that we might use? Well, there is evidence for using opioids to reduce chronic cough. It's tricky to find any evidence about what dose we should be using, so I would tend to use a breathlessness dose, which is about 25% of an opiate, of a pain breakthrough dose. There's other studies looking at inhaled sodium chromoglycate, and actually that can be very good in reducing breathlessness, predominantly in adult studies and on adults with lung cancer. But the evidence is sufficiently strong for its benefit that certainly for adults it has been recommended as first-line management for treatment of cough. If you're struggling, you can then move on to things like gabapentin and pregabalin. Again, there's evidence that both of those can help reduce cough and reduce cough in palliative care patients. Another one that I think is quite a good one to think about is a cough syrup. And parents are often asking us, can I buy them a syrup from the chemist? Well, there's not very much research, in fact, there's not any that I could find in children's palliative care, but there is research looking at cough medications for acute cough in children. And one particular study that looked at honey preparations in children aged 1 to 5 who had an acute cough and sleep disturbance. And what they found was that honey preparations are better than a placebo. And honey preparations are the only over-the-counter medication that's been proven to be helpful for managing cough in children. So it's an easy one to do at home. It's cheap. You can either buy some or you can make some. But try a honey preparation for chronic cough in children with palliative care. The next one that I was going to talk about was hemoptysis, which I think everyone knows is a horribly frightening symptom. Good news is it doesn't happen that often. But when it does, it's horrid, and it's also the thing that we all worry about an awful lot. Well, there's really mixed evidence for the role of a lot of the drugs that we would use, or no evidence at all for management of hemoptysis. So mixed evidence for the role of tranexamic acid in preventing or in treating an acute bleed. So there was a Cochrane review that was done in 2013 that thought there was some benefit to using tranexamic acid for prevention, for reducing bleeds and also for reducing the number of platelet transfusions you needed. They repeated that Cochrane review in 2016 and actually could not support that evidence anymore and said there was not enough evidence to say that there's any benefit of tranexamic acid either to prevent bleeding or in management of an acute bleed. There's also no evidence that any symptom management we use in hemoptysis is effective. That's not to say that the medication we use isn't effective. It's just that I couldn't find any evidence to say that it's effective. So what does help? Well, there's a couple of studies looking at, there's one study talking to hematologists about, what do you do? How do you manage an acute hemoptysis? And a study also asking a similar question to nursing staff. And what people said was, actually, the most effective thing, use dark towels to reduce the visibility of the bleeding and stay with the patient. They said that actually the patient usually died in an acute bleed before they could go and get any medication, or the patient died when they went to get the medication, and therefore the patient died alone. Sorry, talking about cough always makes me cough. So dark towels and stay with the patient. But, we all want to use a medication, and anecdotally, what most of us will use will be a combination of morphine and midazolam, usually because we're trying to treat breathlessness and anxiety, and probably because we're trying to treat ourselves. We want to do something. My preferred method is to get a morphine and midazolam patient-controlled analgesia, or proxy patient-controlled analgesia, so that we can deliver frequent boluses of both midazolam and morphine. And I may combine that with a background infusion. But I want something that's up and ready to go, and we can just press a button every 2 minutes, every 3 minutes, every 5 minutes, however often we need to, until we get that patient calm. Because in a massive bleed, they're going to die very quickly. And what we don't want is for them to be dying frightened and distressed. And then retained secretions. So retained secretions and death rattle. It's really distressing for the family. And it can be quite distressing for staff as well. But it rarely appears to distress the patient. And actually, there's a lovely study that's looking at the distress in patients in relation to the severity of the death rattle. And actually, this study that I've made reference to, they had two groups of patients. They divided their end-of-life patients into two groups. One group who they felt had a death rattle, and one group who they felt didn't. And in both groups, they measured every day a daily death rattle intensity, and immediately afterwards, they measured their respiratory distress observation scale. So they measured how strong was their death rattle and how distressed were they. And there is absolutely no difference in respiratory distress between patients with and without a death rattle. So the evidence says it is not causing distress any more than if they didn't have a death rattle. And there was also no correlation between the intensity of the death rattle and respiratory distress. So a really loud death rattle doesn't mean they're very distressed. The volume has nothing to do with it. It is just the noise of retained secretions, and they haven't coughed them up or swallowed them. I never know if this is good news or bad news, but there's no evidence that any medication is better than a placebo. So it's almost, not worth using anything in many ways. There's no evidence that anything we might use will work. However, there is a study that showed that glycopyrronium works a little bit better than hyoscine. So overall, the systemic review says nothing works, but actually there is a study that says, well, glycopyrronium might be better than hyoscine, but actually neither of them work. So I've whizzed through all of this a little bit. So I'm just wanting, in my last few slides, just to summarise everything I've talked about. If you've been asleep up till this point and you want to get something, just take photos of the last couple of slides because they've got everything on it. So, recommendations for dyspnea management. Start with a fan. It's cheap, it's easy to use. You can be using a fan while you're writing up other drugs. So just go for a fan, really, really easy. It's safe. The only side effects I've heard of is children getting them caught in their hair. So if they hold them too close and you've got long hair, not a problem for me, unless I kind of hold it here. But that's the only thing that I've come across. So definitely think about a fan. It's not going to do any harm. With oxygen, there's no proven benefit that oxygen is any better than room air. But we also have to remember that room air through a cannula is the same as room air through oxygen. So it's not that you're doing nothing. But I do wonder if it's just doing the same as what a fan would be doing, that it's the airflow that's somehow benefiting. But there is some evidence that people who are more dyspneic might have some benefit from oxygen, and it will be within the first 48 hours. So I think we could offer oxygen, but we can discontinue if there's no symptomatic benefit. But I don't think we should be falling over ourselves, rushing to get oxygen for patients who haven't not got low baseline saturations. First line medication is usually going to be morphine, very good evidence for it. Probably we should use 25% of the pain dose. There might be some benefit to fast-acting preparations, and there might be some benefit to using nebulized fentanyl. If we're going to reach for an anxiolytic, we know that there's some benefit when morphine and midazolam are used together. So morphine should probably be our first line, either with as-needed midazolam, or my preferred, based on the studies, is regular midazolam. So regular midazolam plus regular morphine with extra morphine as breakthrough if we need it. And then for breathlessness, don't forget the non-pharmacological interventions such as self-hypnosis, such as breathing techniques. We really should be using these as part of routine management. And we know which of our patients are likely to get breathless, so we can teach them these techniques early on, so that they've got time to practice them, so that when they really need them, they can use them. So recommendations for cough management. I like to start off with a honey preparation because it's something that a lot of families can do almost immediately. It's cheap, although honey's getting very expensive, but it used to be cheap. It's relatively easy. You can make it at home. A bit of honey mixed with water and lemon. Definitely worth a try. We should probably be thinking about inhaled sodium chromoglycate. I quite like that if they're either not on an opioid or they're already on an opioid for pain and they're still coughing. Try something different. From personal use, I've had mixed responses. Some children who've responded well and some who haven't. But it's quite an easy one to try. With opioids, we know they work. There's evidence for that. I can't find a consensus on dose, so start low and increase it if you need to. And then if you're really struggling, think about other options like gabapentin or pregabalin, and you can do a literature search and find other meds as well as your next steps. For hemoptysis management, tranexamic acid, the jury's out, really. Some studies say it helps, some studies say it doesn't. First Cochrane review said it might help, second Cochrane review said it might not help. There's a chance it might be helpful in preventing bleeding, so it's something to think about in individual patients. Perhaps a patient with hematological malignancy, you might want to have them on tranexamic acid because it might help, it might reduce the amount of platelet transfusions they need. But I certainly wouldn't push for someone to be on it because the evidence isn't really there that it will help. The most important thing, if someone has an acute bleed, stay with the patient. Stay with the patient and use dark towels. And reassure them and try to stay calm. And as I said, no evidence for any symptom management drugs really, but actually, anecdotally, most of us like to use a combination of morphine and midazolam in a form that can be given quickly and repeated easily so that the patient can dose up to the dose that they need to be comfortable. And for secretions, the main thing I would do is try and reassure the relatives that actually there's no evidence at all that noisy secretions are causing their child distress. The things that I favour doing, things like postural drainage and suction. So rather than reaching for a medication, positioning the child so secretions can drain out, perhaps some gentle suction so that we can just clear some of the bubbly secretions that are causing the relatives to feel anxious. No evidence that any medication works more than a placebo. But equally, we do all sometimes like to try a medication. And as I said before, the studies are all done in adults, so children are different. So I think it's reasonable sometimes to do a trial of a medication. So, we can trial using something. If we're going to use anything, evidence suggests glycopyrronium might be better than anything else. So I would start with glycopyrronium. And I think that brings me to the end of the slides. Now, I think the slides might be... Are the slides available afterwards, after the course, for people to download? I think they might be. Anyway, if the slides are, if you download them, you'll also get my little summary of all of the papers, if that's helpful. But thank you very much for listening.